Good morning, everyone. We're trying to have more people join, so be patient with us. We're going to start like a minute past 11 just to give more people time to join. Thank you so much.
Good morning, everyone. Bear with us. We will start in a minute or so. We're allowing a few others to join before we can start. Okay, I think we will go ahead and get started. I'll start off with a few comments regarding our housekeeping here, but also the procedures for the day. My name's Abel Ekiri. I'm your host today. I'm a veterinary epidemiologist that's based here at the University of Surrey, and I'm hosting the webinar in coordination with our project manager, Chika. You will notice that the session is broken down into the following. That is a brief welcome by myself, where I'll give a brief background about the network, followed by a presentation by our presenters today, and we'll wrap up with a Q&A towards the end, and we'll close towards the top of the hour. Feel free to introduce yourselves in the chat if you want to, and remember to keep your microphones muted if you're not speaking. And if you have questions, raise your hand either during the session or during the Q&A, which will come towards the end. But also feel free to use the chat function to insert your questions that you may have as we go along. The recording will be available on the network page at the end of the session. So briefly about the network, and this is really for the benefit of those who may be attending our webinars for the first time. The People AMR network brings together researchers from various disciplines that are working on AMR to identify ways to develop, evaluate, but also implement interventions that do promote prudent use of antimicrobials in the community. Our team currently has a membership of over 240. And just below this, as you see on the slide, the leadership for the network, that is Professor Sarah Tokin-Crime from University of Oxford, who's the network lead. And we have 4 co-leads, Gail from Oxford, Sue from Reading, myself, Abel, at the University of Surrey, and then Wendy at the University of Manchester, and our project manager, Chika, who's also co-hosting this webinar today. Our target audience is everyone in the communities that are using antimicrobials, and we categorize this in 2 ways. That is the prescribers, and these could be the different health professionals, whether those be veterinarians, dentists, pharmacists, but also GPs. And on the other hand, we have the users of the antimicrobials within the community, and those cut across the animal settings, but also within the human communities across different sectors, whether that be homes, schools, and so on and so forth. Our aim in this network is to co-develop stewardship interventions with users and prescribers at the forefront of what we do, and specifically to identify those interventions that can bring sustained behavior change. We are working across disciplines, as you can see on this slide. We do provide opportunities for collaborations with expertise outside one's home discipline, and we are interested in integrating a variety of expertise, but also study approaches to design interventions. The network activities are varied. Here is just a quick listing. These include building networks and collaborations, knowledge exchange and dissemination, early career workshops and placement activities, and these are constantly ongoing. And we also have webinars and events, today's, which is an example. And lastly, joint funding applications, just to mention a few. For this webinar today, we are partnering with the International Center for Antimicrobial Resistance Solutions, in short, ICAS. For those who may not be aware, ICAS is an international organization working in over 35 low middle-income countries to co-develop and implement context-specific solutions that address AMR. We are pleased to collaborate with ICAS through knowledge exchange activities that are focused on AMR, behavior change, and stewardship within the global health context. And this collaboration does align with the People Network commitment to supporting interdisciplinary, but also international and practice-relevant approaches to addressing challenges around AMR. This just to give you an example of the webinars that we've hosted in coordination with ICAS in the past. And as you can see, these are creating opportunities for our network members to learn from international perspectives, but also share expertise across disciplines. And obviously, these sessions have highlighted the importance of understanding AMR challenges within local LMIC contexts, but also they've opened up useful conversations around potential future areas of shared interest. As you can see on the slide here, our current presenters are highlighted in red, and those are the speakers we'll be listening to today. Next, I'll briefly introduce our speakers today, and that is Dr. Seng Chan Kunavo, as well as Dr. Kanchana Tilaku, who will use participatory approaches that engage healthcare workers and key stakeholders to enhance AMR action within health facilities in Lavu. And briefly, Dr. Kunavo is a public health researcher with over 40 years of experience of working around antibiotic use and resistance among pregnant women, mothers, and young children, but also is involved in research capacity building in Laos. And Dr. Tilaku is a community health researcher at the Ministry of Health in Laos and has expertise in infectious diseases, public health, and AMR program implementation. Over to you, Dr. Kunavo and Dr. Tilaku. I'll stop sharing for now.
Yeah, good morning, everyone. I will share my slides first and okay, today I would like to share with you all how we apply the responsive dialogue for designing our AMR intervention in the health facilities. So this is from our experience since last year. So I will share the slide with Kanchana later on. Kanchana will share about what the implementation that we start in Laos. So the main project, is the maternal and child health AMR project, aim to improve appropriate antimicrobial use. At least we would like to at least 30% better among women during pregnancy, childbirth, and postpartum, and among children under 5 in Lao PDRs. And then one of the objectives is how we can identify the solution to enable change, attitude, behavior, and practice toward the antimicrobial use and antimicrobial resistance in the obstetric and pediatric in the healthcare facility. So then for this objective, so we apply the responsive dialogue guideline. So this project is funding support from the ICAS. So we start the study. We selected at least because it is just starting. We would like to do any intervention to the health facility. So we selected one province, and Vientiane province, and one is the Central Hospital, maternal and child health as well. So then we aim to start in 2 districts. So in the background, these 2 districts, we already start some research and then we identify a problem related to AMU, AMR in the areas. So then for this, we also plan for, we would like to do any intervention that can improve all of the antibiotic use in the areas. So we chose the 2 districts, is the Phuong district and Vang Vieng district. Vang Vieng is in the town. This is a district in the town, and then Phuong district is communities, is a bit rural. However, both of the areas are tourist, so where the tourist hotspots are very famous for tourist hotspots in the areas. And then we're looking at some health facilities. This is local area for study on the communities as well. And the timeline for the responsive dialogue in Lao PDR EVUs is we divided in 3 stages. The stage 1 is we did the groundwork. So we start with the stakeholder mapping, and we working with the research team and facilitators to design all of the conversation event and develop content of the conversation event, and who will join on the event as well, participant selection and invitation as well. So the groundworks we did in Vientiane province, in Phuong and Vang Vieng district, and in also in the Vientiane capital on the maternal and child health. And this is during this December to July 2025. And on the stage 2, we start the conversation event. It takes around 1 month during August to September. And then after that 1 week, we also further to go to the stage 3. But I will go to the detail what we did in each stage. So for the groundwork, for the stakeholder engagement, we also visit the provincial level, district level, and community level. We're working with several stakeholders, so including for the administrative office, member of the provincial assembly, Lao Women's Union, and Lao Youth Union, who are working closely to the community because they have the vertical line of working with the communities directly. And then in the community level, we work with the Hmong mothers, pregnant women, postpartum women, and women with the children under 5, village authorities, and the owners of the convenience store, because they have also, they sell the some drugs. And we did focus group discussion in the interview among all of these stakeholders. And at this stage on the gravel, we also starting to decide how we do the conversation event. We draw up all our plans, and then we decided that the event should be about 3 days of the workshop. We use a responsive dialogue workshop. We develop the content of the conversation and develop monitoring framework and action planning and commitment as well at this time. And we expected to understand all the system and mapping of the landscape. And then we will also plan for the dialogue for behavior change and solution building. And then we decided whom we recruit as participants. So we decided in 2 groups. First is the healthcare system stakeholders, and second group is community stakeholders. So because we would like to do intervention in the health facility, so then this and the community stakeholders mean there's own our user, the service user and caregiver. And then after all the preparation for recruitment of participants, we set the stage for the conversation events and organize all logistic and materials, event and all arrangement for participants' travel and accommodation. So all the steps of the groundwork as in the guideline on the RD, responsive dialogue guideline. So we follow all other steps. And on the stage 2 is directly to conversation events itself. So conversation event 1 is that we conducted is in separately in Phuong district and in Bang Vieng district separately occasion. And then in each district we have one day event. The conversation we run for 1 day. So on the first event, we aim to identify drivers of inappropriate antibiotic use and behavioral barriers using program 3. So the key session and question in this time, we share our we give them some experience, some ideas, and then later on we ask them to share what the real life experience, because we include both own groups, 2 groups, healthcare providers and communities together. So then they can share the real life experience, how they with the infection prevention, antibiotic use and resistance. And then we also ask them thinking about using the program 3 from the stories. So what is the main problem in each team? Is mainly because on the first events we invite the participants around 62 people in both districts, and then we divide them in group and asking them how they use program 3 from their storytelling about the AMR, AMU, IPC story, and then they put the idea on using the 3 to describe. They can brainstorm all the factors contributed to this program and what is the main program, the cause and the effects of the programs. And during the first, I think the event 1, so the course we identify this 4 areas of the course of the program. So related to patient, family, and community factors is in the community still have limited knowledge of AMR and high self-medication still. And they have also culture expectation, reluctance to follow the IPC advice at home. At the health system and health facility level factors, so they have limited IPC resource, overcrowded and understaffing, lack of AMU stewardship, diagnostic limitation, and antibiotic supply chain issues. For the healthcare provider itself, their behavior and practice, this is we identify prescribing habits, low awareness or training gaps about the AMR, and poor adherence to IPC protocols. This is also influence from patients or families as a program in, I think, as in low, there might be many low income countries, patients and families also ask doctors to prescribe so that the antibiotics for them if they don't receive the antibiotics. And another cause are policy and governance gaps. So no SOP for specific AMU or IPC, and they have limited national AMR awareness campaigns targeting maternal and child health. So we have national AMR guideline, but it's on general population, but not focused directly maternal and child health. But now, so I think we will start to focus on that. And after that, we arrange after, I think, another week, we start the conversation event too. So at this time, how we can start the dialogue for behavior change and solution building. So we aim to facilitate inclusive dialogue and to co-develop strategy that address identify behavior barriers using responsive dialogue tools. So we continue to do the story circles, and then we sharing life experience on the starting build any ideas for change, and then we do the solution clustering. In this event, we use the combi model. The combi model is on the how we look at the capability, opportunity, motivation, and behaviors. So this is as a framework. So then this is a framework used to understand and change human behavior, particularly in the context of health intervention. And it can apply to analyze and address challenges related to IMU and IPC. So we use this combi model to work on. And this is an example how we identify on the component of the combi. So so for the community group, they're also working on the course at the community setting and the healthcare settings. They're working with their own healthcare professional who join the event. So the participants who join the second event is the same participants who join on the first event. So it's around 62 people in both this. I mean, altogether, 2 districts is around 100, more than 100 people. And this is at the community level. We still have limited knowledge on antibiotic, misunderstanding about completing antibiotic course, and low awareness of AMR and long-term risk. So at healthcare facilities also, we identical refresher training, limit awareness of hospital-specific AMR trends, and unable to communicate with patient and loss of follow-up. This guy, and another problem in healthcare settings is shortage of diagnostic tool, lab capacity for infection confirmation, and inadequate facility of supply for IPC practice. And opportunity, we also identify in both and community setting and healthcare setting. And in particular, the opportunity that they can easy access to antibiotic without prescription. So and distance to health facilities is a bit far in the communities, and then so why they also use some medication. For sanitation and water access as well in the community and in the health facilities or another constraint related to the pressure from patient or no SOP on specific AMR IPC, for example. And for the motivation on so they have some some course that how is motivate how they use a antibiotic in both community setting and healthcare setting. And so later on we try to identify the potential solution. It means the team, the group, the stakeholder who come together and working on this. So I think they identify the potential solution is cover about 4 areas. And for example, in Vang Vieng district, they're talking about community knowledge and awareness, communication and media tool, health facility experience and equity, and pharmacy engagement and patient support. I think and in both districts similar things, but I put the details here that in Vang Vieng we try to so that in summary the community knowledge and awareness they say empower the community with accurate information. And the idea on the media is maybe reinforce learning through accessible cultural format. So we will work, the idea is proposed to work with pharmacy and patient support and also foster trust and inclusivity and equity access in health facility as well. And in the farm district, I think it's a similar thing, and we go faster on this. Community knowledge awareness, communication media and tool, and health education integration, and pharmacy engagement. So in both districts, so we will use both the how we can load a logic package of intervention should address on capability, opportunity, and motivation. So capability, knowledge, education, and we will directly map onto the combi model. So how we can tackling the behavioral determinants of inappropriate antibiotic use and resistance in the community. Then after 1 week, we move to the conversation 3. So how we can co-create it or action planning and commitment. So in this, we aim to translate the dialogue into concrete action and commitment. So how we divide as in the 2 days, the 2 days workshop. So we divide it in 3 sessions, the session of implementation planning, monitoring, evaluation, and feedback, and commitment. And what is commitment of all stakeholders, how we work on this improving for the maternal and child health related to AMU and AMR. So then we plan to have to identify to each solution. So the stakeholder should work. I mean, stakeholder both in community groups and in health facility group need to identify what they can test in the next 3 or 6 months. This depends. And then they will we ask them to assign champions or responsible actors who should lead the activity in the health facilities. And they also can list own support they need. And then they also have thinking about indicators, monitoring and evaluation, how it will work or not work. So we have all the guide questions for them. So working on the community, how it is related to community knowledge and awareness, communication, media and tools, and pharmacy engagement, patient support, for example, and health facility experience equity working. And so we provide them on the worksheet, the question guide, and then they are working and planning on all of this during the 2 days workshop. So, and then we list all of the potential solution for them. So they are grouping, they all are grouping in the areas capacity building, governance, guideline, monitoring feedback mechanism, and what's any experience or resource they needed. Okay, and then we the aim is that the solutions could test in the next 3-6 months, because our project is run for, we have another 1 year of intervention, so at least they have to thinking about provide us the solution that they can run by in their health facility during this, and what resource they need and what activities they will do and who will work on this. So at least they have provide a commitment to work on the intervention. Okay, and this is the list on the detail. Okay, during this, the list all of the details. I will not go to the details, but here is like what they think, what they plan during for the capacity building and human resources related to AMS guideline training or IPC training, and then what the improving patients' health education on AMR, AMU, and how to improve the service. So they give the implementation steps, timeline, key indicators, assessment, and resource needed. So I think the list on we identify seven areas: strengthen governance and leadership on AMS and IPC guidelines and standard of both IPC and AMS, and monitoring framework and reporting. Okay, they also are clear and plan of all of this, and including all the communities in relation to health education as well. Okay, and what the decision they made. Okay, for the stage 3, I would like to invite Dr. Kanchana. Could you continue for this intervention package?
Yes, sure. Thank you, Dr. Sangjan. So now I'm going to continue with the stage 3 of the, after we have conducted the 3 conversation events. Of course, we have the list of solutions, and we have another section where we have to really select what solution that will be really implemented. So all stakeholders are invited, and then like work together what really the priorities, within the ICAS project that gonna we have to implement it soon, and then it's going to end it in 1 or 2 years. Of course, we cannot do everything, so we have to select what is the most essential interventions or activities that will be implemented. And as we know that the scope of the project is within the hospitals, so most of the interventions or activities that will be that are selected to implement it, therefore within the hospital environment. So of course, the community idea is also integrated, but in a way that can be integrated in the hospital settings. Yes, next slide, please. So in these studies, in this project, at the end we come up with 3 main packages of the interventions. So package 1 is the antimicrobial, is the AMS intervention package, and the hospital, at the end, they decided that, so we're going to focus more on OBGY wards because that's the most problematic wards for the MS membership. So in this packages, we have 3 main interventions. First is to strengthen leadership and accountability for MS, because the hospital sees that leaderships and accountability of them is very important for the implementation of the AMS program. And then the intervention 2 is that we aim to improve the antibiotics prescription especially when we would like to access whether the doctors follow or not the guidelines. We really need to have the quality prescription. So this is also one aspect that the hospital and also the ICAS team agree that we have to work on this in order to systematically improve the data collection process and also to improve the data quality of the hospital. And then and also I kind of overlap with the intervention 3, where we improve the patient's records, because when we improve the structures of the patient's record, it can also easily like follow with an antibiotics prescription guideline evaluation. And also we did the training on the use of antibiotic guidelines also. That's also included in the intervention 2. Next, please. Yeah, I have already go a little bit on the detail of this. So as in the hospital, before we implement our intervention, they are already have their kind of DTC committees. So after we discuss with them, with the hospitals, they agree that okay, we gonna, because there is no specific role on AMS before our interventions. So the hospital agrees that okay, to make this or to strengthen our leadership and accountability for AMS implementation, then we agree to assign the specific persons on the AMS. And then we agree that we're gonna try to allocate specific budgets for AMS activities, and in order to make this intervention move forward. And also we also create our communication channel in order to facilitate our communications. Yes, next slide, please. Yes. So the next intervention is to improve the antibiotic prescription guidelines, use and training. So this activity, we focus more on the guidelines. For now, the guidelines for the obstetric antibiotic use for obstetric ward has been already like finalized or already like used, already applied in the hospital. So we have kind of revised and built and created another like antibiotic prescription guideline for the and then we disseminate it to the targeted hospital, and then our experts also train how to use that guideline in their wards. So our primary target groups are MS committees, doctors, and clinical pharmacists. I would say pharmacists, because in Laos, clinical pharmacists, we don't have that much. So the pharmacists are also involved, including nurses. So with this guidelines, you like also to assess like their percentage of compliance or of the guidelines. Yes, next slide, please. Yes, and the next one is to improve patients' record, as I say, to assess the quality of the data. So we also focus on to improving patients' record, that will allow us also to follow up with the compliance of the antibiotic prescription of the doctors. Yes, next slide, please. Yeah. Yeah, and also we do the MS monitoring and assessment. We did the PPS, we did the audits, and also like each month we kind of randomly selected the patient's documents, and then evaluate and then see if the doctors compliant with the guidelines or not. Yes, next slide, please. Yeah, and then there is also a report and feedback mechanism. After we did, for instance, we did the PPS, after we did the audits, or after we did we ran down we analyzed the compliance of the documents, then we report it back to the hospital, and then we give them feedback, and then we compare. We show them like between this hospital, here is the result, and that encourage hospital to to kind of I would say it creates the competition between hospital a little bit to move towards compliance to the guidelines. Next slide, please. Now the package 2, focusing on IPC. So IPCs, we have of course 7 components, but here we cannot focus on everything. So we target on like hand hygiene and environmental cleaning as a key components. Yes. Next, please. Yeah, so for hand hygiene, of course, we provide them with the training. So we train them with all 7 components, but just the evaluation that we focus on hand hygiene and environmental cleaning. And then we also provide them with guideline, posters, and also like some basic supplies like soap and sanitizers. Yeah, so our main group is the IPC committee, doctor, nurse, midwives, and also cleaners. So are also included into our project. Yes. Next slide, please. Yeah. So and then we do the environmental cleaning. Yeah. Okay. And then we do the environmental cleaning intervention. This also included in the training with like with the 7 bundle of the IPC, and then the intervention we focus on the observation of the environmental cleaning among healthcare providers. And yes, the same. Our target group is exactly the same. Yes. Next, please. Yes. So for the assessment of the hand hygiene and the environmental cleaning, so we did the observation every 3 months. So for hand hygiene, for instance, we observe like 2 weeks, like 14, like until we reach like 200 opportunity of hand hygiene according to the WHO guidelines. So we do the observation every 3 months, and then we switch between like core team IGAS, and then the next round would be the local hospital. Is kind of to see the difference of the result, as well as also to build to focus on capacity building for local healthcare providers, local health professionals to be able to evaluate themselves, how to observe the hand hygiene, and also how to evaluate the environmental cleaning as well. Yes. Next, please. And package 3, this is focused on the is inspired by the community idea, where especially about their knowledge, where they're required, like they need more education on antibiotic use. So it inspired us on this to build this work package. So work package 3, that's focused on patients education and follow-up package on AMR and IPC. So not only AMR, but we also integrate IPC here also. Yes. So here we focus on building from like hospital side. We focus on building health education team at the hospital, and then we train them on how to provide health education. We also provide them with like information sheet. We provide them with flip chart or something like that to facilitate them in how to providing health education to the patients who come for the services. And then there is also a phone call and follow-up with postpartum women, especially on antibiotic use and IPC. Yes. Next, please. So yeah. So until now, we already have our health education team at the hospital, and then they are all trained, and like they now started to like little by little deliver like the health education to the patients who come for the services. Yes, next please. Yeah. And at the same time, when patients come, they give the health education, and also they provide the no prescription to the patients, to the mother, postpartum mother. And then also when we put also the poster, IPC poster at the respective wards, and also the phone call follow-up with postpartum women regarding IPC. Yeah, we also do that. Yes. Next, please. Yeah. That would be all that intervention that we have implemented in conclusion. So 3 main packages: AMS, IPC, and the last one is the health education. Yes. Thank you very much.
Oh, thanks a lot, both Dr. Kunavo and Dr. Tilako, for pretty comprehensive and detailed work that you all have done in Lao. I like the systematic approach to it, especially going all the way from the bottom up, using those stakeholder mapping early on, followed with the conversation events that you had using that tree approach, looking at the branches, the trunk, and the roots to inform this upstream work that you've rounded up with. Pretty comprehensive for sure. I will open up the floor for questions. If you have questions, feel free to raise your hand. Alternatively, post questions in the chat as well, and we'll get to them. Yeah, to start us off, I have a question on something that you shared there towards the end, Kanchana, around patient education. I know you mentioned something around targeting the patients that are coming in, whether those are the pregnant women that are coming into the clinics, and targeting them with education materials as they go home. And I was wondering if you are expanding that to include the prepartum women, as in those that haven't yet showed up to the health facilities, but they're out in the community, whether you are doing something similar in addition to what you're doing to those that are coming within the health facility settings.
So you mean from our project?
Yes, as in the patient education intervention that you are working on. I think your key target is those that are coming within the health facilities. And the question is whether you are extending that outside the health facilities, as in the community. Are you targeting those that are not necessarily showing up? And this could be family members or prepartum women who are showing up for the routine checks, but they are not necessarily coming in for a given condition or a given complaint within the healthcare facility.
I would say directly might be, maybe not really, but indirectly. For instance, when matter come to the healthcare services, usually they come with their family members. So if they come with the husband, so they both are informed that with health education. And also with that prescription, when they bring home, it also another like indirect way to inform the family members according to the limitation of the project right now. So we can mainly we focus at the hospital settings, but the flyers or the what we provide to the patients, that will be indirectly influence the community members. And also the implementation of the responsive dialogue. We very engage all the community members into our conversation events that would also indirectly influence behavior of the communities, and also it will allow community to reflect more on the antibiotic use in the community settings. Yes.
Can I add some more? Actually, our program, our project is, we have another 1 year, but the aim is that the education team at the healthcare facility, they already learn, and then they will produce the video, things about this, and then in the discussion, we mentioned about that in the future, I mean, after the intervention, they will continue to use that for the postpartum mother who come for the well child clinic, and who join when they come to the hospital. But the main thing is we focus only in the health facilities, but no activities in the in the communities.
Interesting. No, thanks a lot for that. I see a hand up. Hele, go ahead, please.
Yeah, thank you, and thank you for a very interesting and comprehensive presentation. I think what you're doing is both very interesting and inspiring and important, actually. So my question is just, are you able to say anything at this point about preliminary results of this work, or is that too early? And maybe in connection with that, if you can talk about some of the challenges or barriers that you are seeing in your work. But thank you very much.
Yeah, thank you for a very good question. But right now we just started the intervention in the first 3 months. So we only just start to get the first, I mean, after 3 months of the intervention, and then we did some follow up and feedback and evaluation of all the things. So then right now we don't have yet, but some I think the challenge, of course, we will identify very soon, because during the intervention process also, I think, yeah, maybe I have no right to say yet, because just last week, the team are just returned from the field work, and then we will meet next week, next month. So to discuss all the things, how we improve on the continuation of the support the team to do the intervention. Thank you. Kanchana, anything else to add?
Maybe not yet. Yeah, of course there are some challenges, but maybe next time, if we have an opportunity to disseminate our results, then we can share you more on that. Thank you very much for your question.
Thank you. And I mean, I totally recognize, of course, that it's early on. So I was just interested to hear if you had sort of, in terms of how it's been received by the people that you've started working with. Thank you.
Yeah, thank you all. Wezo, I think you have your hand up.
Yes, thank you very much for a very nice presentation. So I've been following your project for a while now, and it's really interesting to hear that what you have done. My question is regarding the guidelines. So you are one of the few projects that have used the responsive dialogue guidelines and applied it to inform your interventions. How was your experience working with the guideline? Because the guidelines are supposed to be interactive and useful. Were they useful for you? How difficult was it to apply it? We have heard that some projects find it really practical to use because it guides you step by step. Other projects find it really complicated to use. So I just wanted to know how did you experience the use of guidelines, the responsive dialogue guidelines? Over.
Cảm ơn Tùng.
Yes, for us, we find that the guideline is very useful because there is like every steps that we can follow from like even conducting groundwork until the end. So we also apply some like materials in the that have been mentioned in the guideline also, for instance from problem 3, this kind of thing. So it's very useful for us. And of course, we also have to adapt to the local context also, again, to like, even though we have like that standard guideline, but we also have to conduct to the Lao context. And in order to work, and we also work closely with ICA's team, for instance, in order to work with the community, we have to engage every level and then work all together, and then everyone are involved. So yeah, we found that it's very useful, the guidelines, and really practical.
Thank you. And can I just ask Abel one follow-up question? That's okay. It's just because of the adaptation. So what sort of adaptations did you make so that the guidelines would be useful for Lao? Like, what did you change? Do you remember something? You said you have adapted it to the Lao context. What does that adaptation mean from your side? Over.
I think we the situation of the event, okay. We also have a support from the example from Thailand. I mean the expert from Thailand who used the RT tool before. She also come and support us. And then during the time, and then when we look at the event, when we arrange the event, how we can arrange the event for the whole day, for the 3 days workshop and 3 times, and how to bring people together. So we adapt, like we did not follow Malawi, we not follow Thailand, but we use our own context, like we could not bring all together for the 3 days workshop. We could not do that. Then at least we can have a 1 day workshop, but we bring all together, but not at central level, not provincial level, but we come to the district level. So the community is close to the district and the central can also go to the district, this kind of thing. And then we make the event only just 1 day because people in the community, they could not stay more. They could not, I mean, they stay longer. So then at least, and then we asking them, okay, we have 1 week further for them. And then we invite them again. And then we said, okay, next week we will see it all together and then the same person, not the new person, this kind of thing. Then we discuss with them, and then people survive that we have separate 3 events, 1 day for the 1 day workshop and 1 week apart. And then we have 3 times. This, I think that this kind of adaptation we did. And we did also bring all together, not separately, because in some area they work with the national level, they come to provincial level, district level, but we bring all together from the central level. People from the ministry sitting down and listen to the communities, the person or woman who can tell some story to tell them. It's not easy, but it works. I like the idea that we bring all together, and because the doctors or the nurse or who are working in the hospital or people working at the ministry, they also hear what a little complaint, a little complaint from the patient or from the user or from the community's people. I think this is a small adaptation we did.
Yes, and I would like also to add one thing that we also learn every day, because we did it like in Vuang and then Vang Vieng differently, and then we also adapt day by day. This time, especially dealing with the power dynamic. At the first, we like mix everyone together, like the health professional in one group with community members, and then we kind of like make them like in one group where they can. At the beginning we thought that it would be very useful to allow them everyone to discuss all together, like every level, like the director, the technical staff, and then the community member together at the same group where they can share their experience. But at the end we found that okay, the one who have more voice is the one who have more powers. So and after that we kind of change our way of organizing the event, and then we separate. Okay, maybe the high position with high position, technical staff with technical staff, committee member with committee members. So they have like even like more safe space for them, like where they are at the same level, they can easily discuss. So we also adapt this kind of thing also to reduce power dynamics and then understand more the community perspective. Yes.
There is quite a lot to take away from here, Wezo. I like that question. And I think there are lots of lessons from this that can be taken forward. If you're thinking of translating this to other geographies, other countries, I think there's a lot to learn from you. What you just described there, I wish you could put it in writing, because I can see that being useful to so many other teams, and how best you can modify those guidelines to better suit different contexts. I see our time is up, and we'll wrap it right now. And I want to say thanks again to both of you for taking time to share your very interesting, comprehensive, very extensive work that you all have done. And I'll pass this on to Chika, who has 2 slides to share before we close now. And let me see if I can quickly bring the slides back up quickly. You should be able to see the slides, Chika, right? Can you see the slides, Chika?
I was busy talking to myself. My apologies.
Yes,
Oh,
we can
sorry.
see.
Sorry about that. So thank you so much for this session. There's so much to unpack from today's presentation, and it's something that I'll personally go back and have a look again. So thank you, everyone. The recording for this section will be on our website shortly. And we would like to inform everyone we're taking a break in August because there will be so many absences due to so many holidays. So we're taking off a break in August, and then we start again with our webinar series from September. So for the September session, we have Dr. Rena Richards. She's a senior clinical lecturer in infectious diseases and medical education at the University of Manchester. I'm used to saying Oxford. In this session, she will discuss the growing impact of antifungal resistance, the challenges it presents in our clinical practice, and why antifungal stewardship is more important than ever. So it would be lovely for you to join so that we can also understand about antifungal resistance as well. So if you have not yet become a member of the network, there's a QR code that will come up on the screen, yes. And you can just scan the QR code and then you can sign up. One of the benefits of signing up is that whenever we have any upcoming activity, any upcoming event, any update at all, you will be part of the people that will first receive it. And we also send around newsletters monthly as well. So thank you everyone for today's session, and we look forward to seeing you again in September, and enjoy your day. Thank you.
Thank
Thank you.
you.
Thank
Bye,
you. Thank you,
everyone.
everyone.
Bye.
Bye-bye.